Okay. All right. Thank you so much for having me here. It's a pleasure for me to join you and speak with you today. Thank you, Dr. Boyne, for that tour de force on the present and future state of research in scleroderma. So I'm a lung doctor, and I see patients with primarily interstitial lung disease. But you may know that scleroderma can affect the lung in several different ways, along with interstitial lung disease, which causes scarring and inflammation in the lungs. Patients can also develop pulmonary hypertension, which is kind of at the intersection of the heart and the lungs. But today I'm not going to be talking about the medications that treat these diseases. Dr. Boyne touched on them a little bit. Today I'm going to focus on the consequence or the effect of these conditions on the individual person. As physicians, I think we strive to do more than just treat diseases, than treat lungs or hearts. We're trying to treat whole people. And treating whole people means doing more than just prescribing medications. So no matter how scleroderma may be affecting the lungs or heart, some of the consequences are common. So shortness of breath, some people refer to this as breathlessness or windedness, that sensation that it's difficult to breathe, particularly with activity, is a significant challenge in scleroderma lung disease. And medications, unfortunately, Dr. Boyne covered, are sort of limited in their efficacy. They can treat the condition, but often we cannot reverse the condition or make the condition significantly better. Fortunately, there are some other interventions that can help patients feel better or feel less short of breath while being similarly active or more active. When one feels short of breath, it can be really tempting to stop moving, right? If we become sedentary, if we sit still, then we can avoid that sensation of shortness of breath. Unfortunately, when it comes to strength and muscle, you use it or you lose it. So the more sedentary you are, the more muscle mass you use, the less strong you become, the more difficult it becomes to do the same thing, even if nothing is actually changing in your lungs. So again, there is not a pill that can just make you stronger, but there are some other things that we can do. Anxiety. This can occur even before the onset of any lung disease. I think when someone is diagnosed with the condition, especially one that's not so common in the knowledge among the public, there can be a lot of anxiety about the uncertainty that comes with it. And to be diagnosed with a lung condition only compounds that because shortness of breath causes anxiety. So when patients are short of breath, there's a sensation that we're not getting enough air, that something really bad can happen to us, that triggers anxiety. When patients are anxious, they take rapid, shallow breaths, and that further compounds that sensation of shortness of breath. So it becomes this really vicious loop between shortness of breath and anxiety. And there are techniques that we can teach, that people can learn, that can empower them to kind of break that vicious cycle. And then finally, loss of self-efficacy. If you're not familiar with that term, self-efficacy, it refers to an individual's belief that they have the necessary power and tools to implement the outcomes that they want. And to be given a diagnosis or to have lung disease can really be disempowering. It can take away that sense of one's self-efficacy. And again, there isn't a medication that can fix that, but there are other things we can do. So what are some of those things? So first, let's start with supplemental oxygen. Now, I will say that when I bring up supplemental oxygen for the first time with my patients, I am not met with applause, okay? People are generally not thrilled to have to go on supplemental oxygen. One of those reasons is that it is an external signal to other people that something is going on with your health, that something is going on with your lungs. There also is a cosmetic part to it, right? I think when we put on an outfit in the morning, we're not thinking that a nasal cannula really complements that outfit very well. Also, it can be cumbersome. You know, the lightest oxygen, these portable oxygen concentrators, weigh about 5 pounds, which is not nothing, especially if someone has already become deconditioned or week. But there are significant benefits with supplemental oxygen. So it's not for everyone, right? So when should someone be using oxygen? First, it's important to understand why oxygen levels may be low in the first place. So when you have scarring or inflammation that's occupying good lung space, or you have pulmonary hypertension, that limits how much oxygen can get in to your blood from your lungs. Okay? And so that might not be a big deal when someone is at rest, when you're sitting, when you're watching TV, but as soon as we go to do some kind of activity, there is a supply-demand mismatch. So when we're sitting around, our muscles are not demanding so much oxygen. But as soon as we try to walk across the room, all these big muscles of the leg want oxygen all at the same time. And if you have more advanced interstitial lung disease or pulmonary fibrosis, pulmonary hypertension, your supply is limited. And so supplemental oxygen, it increases the supply so that we can meet that demand. And so some of the increased shortness of breath or discomfort that is caused by activity can be mitigated by using supplemental oxygen. Generally, we want folks to keep oxygen levels above 90%. We periodically monitor in the clinic what someone's oxygen needs are, not only at rest. Remember, it can be totally normal at rest, but when someone goes for a walk, that can decrease. So typically, we'll periodically do a 6-minute walk test. You may have done that in your physician's office to really assess what happens with activity. Cough. Some patients experience terrible coughing from low oxygen levels, and I've had patients with scleroderma tell me that after they start using oxygen with exertion, that cough is significantly reduced. You don't have to take my word for it or the word of other people you may know who use oxygen. We really want to practice medicine that's evidence-based, for which there's good data. And Dr. Boyne highlighted the importance of research. So there was a randomized clinical trial of oxygen in patients with interstitial lung disease. So this was kind of neat. They took about 80 patients, divided them into 2 groups. And all of these patients, they had a 6-minute walk test where their oxygen level dipped to less than 88% with exercise. That's the criterion that patients must meet in the US to have insurance cover supplemental oxygen. So they administered oxygen or prescribed oxygen to half of these people for 2 weeks and no oxygen to the other half for 2 weeks. At the start and end of that 2-week period, patients completed surveys on their physical function and their psychological outcomes as well. And what they found was a significant improvement in patients who used oxygen overall in multiple domains of quality of life. This was what we call a crossover trial. So if you're thinking, how mean, they didn't give oxygen to half these people, after 2 weeks, they switched groups. So the patients who were not receiving oxygen, they received oxygen, and the other group actually stopped using oxygen, and similar findings were observed that oxygen overall improved multiple domains of quality of life, both physical and psychological. In patients who have interstitial lung disease or pulmonary fibrosis who do not have pulmonary hypertension, that is a complication that can develop over time. And low oxygen levels actually contribute to the development of what we call secondary pulmonary hypertension. So keeping those oxygen levels up above 90% can be protective against the development of pulmonary hypertension. When you have one problem in the lungs, you definitely don't need another. So it can be helpful in disease mitigation as well. So we have some photos up here. So on the far right, you see a patient wearing a portable oxygen concentrator. So that's that little 5-pound box. And he's got a conventional nasal cannula in his nose. This guy's got hiking sticks, hiking poles. He's about to go for a walk. And I do have patients who, for whom supplemental oxygen enables them to continue doing the things that they love to do, like hike. I have a patient who plays tennis. He's got his portable oxygen concentrator in a backpack conformation so he can continue to play tennis. Oxygen is like a medication in that it is dose dependent. So it's not all or nothing. When patients start out and need just a little bit of oxygen, 1 to 3 liters, that's when a portable oxygen concentrator like this one is sufficient. Unfortunately, if patients require much more oxygen than that, this small device is not able to deliver it, and that's when patients need tanks. And they can also need the special nasal cannula that you see with the round pendant, we call it, at the bottom, or this reservoir at the nose. And what that does is stores more oxygen so patients can get higher flows. Up on the top left, or the center top, you see a pulse oximeter. I'm sure you guys have seen this before. Maybe you even have one in your home. I recommend that patients, when they're diagnosed with lung disease, do purchase one of these. Now, a limitation in the scleroderma population is Raynaud's. So with Raynaud's, the reading that you get with a finger probe may not be accurate, especially when you're going for a walk. So in the clinic, what we can do is apply a forehead probe so we can overcome that issue. And I do believe that recently there is an FDA-approved device that actually measures, that patients can buy, that measures oxygen on the earlobe that can be more accurate than a finger probe for people with Raynaud's. Okay, so, at the end of the day, best case scenario, if you do, we'll take questions at the end. Okay. Unfortunately, 5 pounds may not be a negligible amount of weight, especially if someone has become weak or deconditioned. So what can we do to help patients improve in those domains? Enter pulmonary rehabilitation or pulmonary rehab. So what is it? Pulmonary rehab is a structured educational and exercise program, and its goal is to improve quality of life and physical functioning in patients with all kinds of lung disease. It has been best studied in a disease called COPD, but we do have increasing data to support its outcomes in improving the lives of patients with interstitial lung disease and pulmonary hypertension. So how does pulmonary rehab work? It's multifactorial. So to increase muscle strength, we have to do resistance training. So we have to lift some weights. They can be very light. They should be very light to begin with. But when we lift weights, we're causing some micro injuries in the muscle. We actually do want those injuries to occur because it's in that repair process that we develop more muscle mass and strength. But in order to create an environment where you're building muscle rather than breaking down muscle and losing weight, we have to complement that with appropriate nutrition. So an appropriate amount of protein in particular that can help us build that muscle back up. And pulmonary rehab covers both the exercise component and the nutritional component. Now, cardiovascular conditioning is really important in our perception of our shortness of breath. So if we take 2 people who have the exact same severity of interstitial lung disease, one person may be a lot less breathless doing the same level of activity compared to the next person if their fitness, if their conditioning is different. And so that cardiovascular conditioning or fitness can be improved with just low-intensity cardiovascular exercise. So that could be regular walking on the treadmill. It could be using this kind of seated elliptical device, but we need some level of cardiovascular activity to improve that conditioning because our perception of shortness of breath is not independently defined by our lung function, and there are these other modifiable factors that patients can be empowered to improve upon. It can be very scary to exercise on one's own, right? What is that safe level of discomfort when someone has lung disease, when someone is already dependent on supplemental oxygen to make those physical gains? It can be hard to know that on one's own. So that's why a supervised program like pulmonary rehab is so helpful, because you have either respiratory therapists, nurses, or exercise physiologists who are supervising and determining that plan to help patients improve. Another thing patients tell me that they are surprised to learn in pulmonary rehab is how to breathe properly. So when you're dealing with perfect lungs, you don't really have to think about your breathing, right? Maybe if you're doing a high level of exercise, then your breathing can catch up with you and maybe be limiting. But when you're starting with imperfect lungs, breathing technique really makes a difference. And so these are some techniques that are taught in pulmonary rehab and patients have told me are helpful. So one of them is pursed lip breathing. So it's a technique in which you inhale slowly through your nose and then exhale through your mouth with pursed lips. And it really helps to have more efficient ventilation when you're working with less than perfect lung function to be able to do a higher level of activity. The other one, diaphragmatic breathing. So think of filling your lungs up in a circumferential 360-degree fashion and also really dropping your diaphragm down. That's that biggest muscle of breathing. And it's really important to push that down to maximize how much air can get into your chest. Not only can that help you just maximize the volume of air, but it can also be a really helpful tool when one is aware of anxiety that's compounding their shortness of breath. I mentioned earlier that a manifestation of anxiety is rapid, shallow breathing. That's actually a really inefficient way to breathe. That's not the way to breathe to maximize your lung function or maximize your oxygenation. And so this diaphragmatic breathing can be a really effective technique in slowing things down, calming things down on the central nervous system level as well to break that vicious cycle of anxiety and shortness of breath. So again, I don't want you to have to take my word for it on anything. There is, fortunately, some really great evidence, so research that supports pulmonary rehab. And so pulmonary rehab increases things that we want to get better and decreases things that we want to see less of. So what are the evidence-based outcomes for pulmonary rehab? First, the best defined is exercise capacity. We measure exercise capacity primarily by a 6-minute walk test. So we calculate the distance one can walk over a period of 6 minutes at the start and end of rehab. And generally, even in patients with interstitial lung disease and pulmonary hypertension, we can see improvements with no change in medications from completion of pulmonary rehab. There are also surveys that we have, validated surveys that measure health-related quality of life. And there are different domains. Usually they can be physical, they can be related to shortness of breath, they could be related to mood. But in general, pulmonary rehab seems to improve these measures of health-related quality of life, muscle strength as well. And then self-efficacy, right? So we're thinking of pulmonary rehab as something physical, but when one is able to do more, achieve more, maintain more of their independence, that contributes and maintains that sense of self-efficacy. And then we can actually measure shortness of breath or one's perception of shortness of breath also via validated questionnaires. And pulmonary rehab does reduce shortness of breath scores and also very interesting to me, reduce anxiety and depression scores. So this impact of pulmonary rehab on mood, anxiety and depression and COPD has been reported for quite some time, but the literature in interstitial lung disease is pretty limited. When I first got to Cedars about 5 years ago, our pulmonary rehab program writes these really nice notes at the end of pulmonary rehab, where it summarizes a patient's 6-minute walk distance, their shortness of breath score, as well as a depression score at the start and end of rehab. And I was noticing for several of my patients that their depression scores were lower, like significantly lower at the end of pulmonary rehab. So I grabbed one of our trainees and I said, hey, Jason, can you look into this? Compare our patients at Cedars who are participating in pulmonary rehab for COPD versus interstitial lung disease, and let's see, what happens to them overall as a group as pertains to these measures. And we were very pleasantly surprised to find that there was a significant reduction in depression scores in patients after completion of pulmonary rehab in interstitial lung disease that was similar to what was observed in COPD. And furthermore, the degree of depression didn't matter. So whether someone had mild depression or more severe depression, completion of pulmonary rehab in our center was associated with a significant reduction in the depression score. Now, for patients with severe depression, this is not going to be monotherapy, but it's really nice adjunctive therapy. I think one of the other significant benefits of pulmonary rehab is community. So especially when it comes to pulmonary fibrosis, interstitial lung disease, that's not a condition that most people are aware of, and family members, friends may just not understand what someone's going through. So in pulmonary rehab, patients meet other people who are experiencing what they're experiencing. And I think that can be a mixed group, whereas a peer group or support group, and it sounds like you guys have some great ones for scleroderma, and there's some through the Pulmonary Fibrosis Foundation as well, that can really be helpful in that regard as well. So not just that sense of community and support, but also education. I think as much as I know about the condition, it's not the same as someone else who is living through it and experiencing it. And so it seems like patients learn a lot from each other that can be really empowering and can really help with coping. One great example of a patient of mine, she had really advanced interstitial lung disease, not from scleroderma, but her condition was to the point where I was really encouraging her to consider a lung transplant. And we had this conversation, over multiple visits, and she really was not budging. And then she came in one day and she said, "Dr. Zaman, I want to be listed for lung transplant." I was like, "Whoa, what happened?" And she said, "I met another one of your patients in a support group, and she had gone through lung transplant. She still attends the support group, and she told me about her experience, and now I'm on board." And I was so thankful to this other patient, and I was so impressed by how much another patient was able to impact the course and treatment of my then current patient. And it really showed me the importance of people having support from others who are going through the same thing and have different experiences and knowledge bases to complement their care. So that is all for me today. So in summary, people are more than their lungs and their hearts. That means we have more treatment opportunities than the medications that directly treat their lungs and their hearts. A holistic approach to wellness extends well beyond medications and is really important in improving quality of life. And these non-pharmacologic therapies are very much evidence-based. They're not stuff that we're just making up and throwing at you. They've undergone research and trials and have shown to be beneficial. Thank you.